The title of this talk is Disorders of the Vestibular and Auditory Systems. These are the class objectives. You do not need to read them. We will use them to chart our talk. The talk will be conducted using conversational and question and answer formats. The first question is, normal people response to those eye maneuvers is under cerebral influence. A true, B false. Those maneuvers can be performed in individuals with normal or abnormal vestibular functions. In normal individuals, we can do those maneuvers while asking the patient not to fixate on a target, in which case the head and the eyes will move together. I will illustrate this occurrence in the next few frames. If we start with the patient's head looking straight ahead and ask the patient not to fixate in any target, and then suddenly turn the patient's head to the right by about 20 degrees, the eyes will follow the head as shown in this frame. If the head, again from the straightforward position, is turned to the left, the gaze will go in the same direction as shown here. This is so because the frontal gaze centers inhibit brainstem reflexes. If instead of asking the patient not to fixate, we ask the patient to fixate on a target straight ahead, the response to the maneuver will be for the eyes to move in the opposite direction to the direction of the head movement. I will again illustrate this eventuality in the next few frames. So we start as we did previously with the head of the patient straight ahead, but we ask the individual to fixate the gaze in a target straight ahead. When the head is moved to the right, the eyes turn to the left. And when from the straight ahead position, the head is turned to the left, the eyes turn to the right. In this case, the frontal gaze center did not inhibit the brainstem vestibular ocular reflexes, and the occipital visual centers acting in conjunction with the oculovestibular reflex kept the eyes on target. So the answer to this question is A, true. Next question. In a comatose patient, those maneuvers that fail to produce eye movements indicate brainstem involvement. A, true, B, false. In the course of answering this question, we will address 4 scenarios related to those maneuvers. Those maneuvers can be performed by moving the head up and down or laterally. By far, the lateral those are more frequently done in clinical practice. Let's talk about the first scenario. I will start by adding the abnormal scenarios that we may find when performing those in order to use it as a roadmap to talk about each of them. So if those maneuvers are performed in a patient with no cortical input to an intact brainstem extraocular movement apparatus, as it occurs in comatose patients with normal brainstem function, we would see the eyes moving in the opposite direction than the face is turned. In this case, when the head is turned to the right, the eyes turn to the left. And when the head is turned to the left, the eyes go to the right. This is referred to as a positive dose. A positive dose means that the area of the brainstem that controls gaze, in this case lateral gaze, is normal. Now we will talk about the second scenario. We will go back to the general chart so we do not lose track of what we are doing. If the maneuver is performed in a patient with brainstem damage, and the damage involves all brainstem, the head and the eyes will move together as the head is turned. I will again illustrate this finding in the next few frames. So, when the head is turned to the right, the eyes will go straight ahead. And when the head is turned to the left, the eyes again will maintain primary position. This is called a negative dose. It implies that the brainstem lateral eye movement apparatus is not working. The third scenario is more difficult to explain because there are multiple possible clinical variants. In this scenario, there is an abnormality in the brainstem, but it affects only a discrete point along the lateral extraocular movement pathway. In this case, the result of dose will vary according to the location of the lesion in the brainstem. But this type of lesion has one thing in common. Eye movements will not occur in a conjugate fashion. An example of this situation will be a comatose patient with a normal brainstem except for a left medial longitudinal fascicle lesion. If in a comatose patient with a left MLF lesion, the head is turned to the right, the eyes will look in the opposite direction. But when the head is turned to the left, the right eye will move to the right normally, but the left eye will not turn in. The fourth scenario consists of peripheral vestibular damage. Here, the abnormality is either in the labyrinth or in the vestibular nerve. Patients with this pathology lose precision and crispness of eye movements. I will again illustrate this scenario. Let's say in a patient with a right peripheral labyrinth abnormality, if asked to look at the target straight ahead and to keep looking at it as we move the head around, and then the head is turned to the left, eye movements will go opposite to the direction of the head movements. But when the head is turned to the right, the eyes move in the same direction as the head. Initially, and only after a few seconds, the eyes dart back to the target. So the answer to this question is A, true. Next question. In a comatose patient with an intact brainstem, when the face is turned to the left, the eyes slowly move to the right. A, true, B, false. Take a few minutes to look at this figure. I hope you recognized all the components. They were all explained in the vestibular physiology lecture. I will make to this figure one substitution. I will substitute the labyrinth by a more cartoonish and simplified representation of the labyrinth, as you can see. This is a representation of the lateral semicircular canal and the ampulla. I have done so because this simple representation allows us to explain lateral dulse eye movements. When the head is turned to the left, the face goes to the left. The back of the head, behind the ears, where the semicircular canals are, turns to the right, thus changing the position of the semicircular canal ampulla, as I have shown in this figure. This creates a flow of endolymph in the opposite direction due to inertia, as indicated by the yellow arrows inside the semicircular canals. The flow of endolymph moves the stereocilia of the hair cell in the right ampulla away from the kinocilia. And in the left semicircular canal, the flow of endolymph, as depicted by the yellow arrow, moves the stereocilia of the hair cells towards the kinocilia. Thus, the right semicircular canal, as a consequence of the stereocilia moving away from the kinocilia, will decrease firing, and the left semicircular canal, as a consequence of the stereocilia moving towards the kinocilia, increase its firing rate. This will cause the eyes to slowly turn to the right. And in the absence of cortical input, they will stay there for a while. So the answer to this question is true. Next question. Dizziness has a clear anatomical correlate. A true, B false. Dizziness is like an elephant. With your eyes closed, you may come to believe you are dealing with many different things. So, keep your eyes open when you see a patient with dizziness. A patient complaining of dizziness may be actually suffering from vertigo. Vertigo describes an illusion of movement in relation to environment. Either the patient feels he or she is moving, or that the world is moving around the patient. At times, the illusion of movement is described by the patient as distant. At other times, vertigo is described as a forceful pull to one side by a giant hand, or as if the body is tilting or swaying. A patient complaining of dizziness may be actually suffering from something else, disequilibrium. Disequilibrium is defined as a sensation of altered stance or gait balance. The reason I place a question mark here is that I have never been able, when talking to a patient, to differentiate between vertigo and disequilibrium based on history. Disequilibrium is often described as a balancing act or as a sensation of being in a boat on a rough day at sea. But then again, so is vertigo. A patient complaining of dizziness may be actually suffering from a presyncopal state. The distinction between presyncopal and vertigo is usually determined by direct questioning. When a patient with presyncope is asked about loss of consciousness, they usually reply, "No, I did not, but I was just about to do so." A patient complaining of dizziness may actually be suffering from ataxia. Patient with ataxia may initially complain of being dizzy, but on close questioning, you will elicit a history of stumbling, and physical examination usually reveals the nature of the complaint, unless the complaint is intermittent, and then you have to rely totally on historical information. Finally, a patient complaining of dizziness may actually be suffering from a psychological disturbance, usually anxiety. Patients with anxiety often complain of dizziness when they are actually suffering from vertigo. Patients with vertigo often complain of anxiety. Hence, a differential diagnosis of an anxious patient complaining of dizziness is particularly challenging. So the answer to this question is B, false. Next question. Which of the following sensory modalities is less important to keep your balance? A, vision. B, proprioception. C, vestibular. D, auditory. Our model of the physical world is provided by sensory information. Sensory information from the vestibular system, from the joint proprioception, and from vision. Labyrinth pathology is the most common cause of misinterpretation of the physical world. Misinterpretation of the physical world often manifests as vertigo. So the answer to this question is D. Next question. The anatomical classification of vertigo has clinical relevance. A, true. B, false. This is a representation of the labyrinth. As you know, it is considered the inner ear. I have now added the external ear and the middle ear. These are the distal vestibular superior and inferior roots. This is the ganglion of Scarpa, the vestibular nerve, the auditory nerve. I have now introduced the vestibulocochlear nerve and a specimen of the brainstem at the level indicated. From the brainstem, fibers go to the brain, passing through the thalamus and reaching the cortex. It can be surmised from the connectivity of these anatomical structures that a comprehensive approach to vestibular system pathology can be constructed based on anatomy. In the next few frames, I will describe an anatomical classification of the most common symptoms of vestibular pathology, vertigo. Vertigo can be divided into peripheral, when they are due to labyrinth pathology, or vestibular nerve pathology. I have now included a cartoonish representation of these structures. Vertigo can also be labeled as central when the pathology is in the brainstem, either in the vestibular nucleus or proximal connections, including the cerebellum. Central vertigo can also be due to brain pathology. So the answer to this question is A. Next question. A characteristic feature of peripheral vertigo is to change intensity according to head position. A true, B false. Vertigo can be peripheral or central, as we have just mentioned. Peripheral and central vertigo have clinical characteristics that often allows us to distinguish between them based on clinical judgment. The onset of vertigo in a patient with peripheral pathology is sudden. The onset of central vertigo is gradual. The course of peripheral vertigo is intermittent. The course of central vertigo is constant. The intensity of peripheral vertigo is severe. The intensity of central vertigo is mild. Changing head position affect intensity of peripheral vertigo. Changing head position tends not to affect the intensity of vertigo in patients with central vertigo. Nausea and vomiting are frequent in peripheral vertigo, variable in central vertigo. Motor coordination is good in patients with peripheral vertigo, poor in patients with central vertigo. Tinnitus and deafness are often present in patients with peripheral vertigo, seldom in patients with central vertigo. So the answer to this question is true. Next question. A characteristic feature of peripheral vestibular nystagmus is the ability of visual fixation to dampen the nystagmus. A true, B false. Nystagmus can also be caused by peripheral or central pathology. Peripheral nystagmus does not change direction with changing gaze, whereas central nystagmus does. Visual fixation inhibits peripheral nystagmus, whereas visual fixation does not affect central nystagmus. Peripheral nystagmus is not purely vertical or torsional, whereas central nystagmus can be purely horizontal, vertical, or torsional. While unilateral horizontal gaze nystagmus can be central or peripheral, bilateral horizontal gaze nystagmus, horizontal nystagmus that alternates direction, and up-beating or down-beating nystagmus are always central. Peripheral nystagmus changes direction with reversal of head position, where central nystagmus usually does not change direction with reversal of head position. Positional nystagmus, defined as a nystagmus that appears or changes in form or intensity after certain position changes of the head, is more common in peripheral than in central conditions. Some clinical findings may help distinguish peripheral and central positional nystagmus. These findings are: peripheral nystagmus presents a delay when triggered. Central nystagmus usually does not. Peripheral nystagmus fatigue with repeat testing. Central nystagmus does not. Peripheral nystagmus is usually produced by turning the head in a specific direction. Central nystagmus may be produced by head turning in more than one direction. With the head in midline position, the fast component of nystagmus due to labyrinth pathology is always away from the site affected. Hence, if the right labyrinth is affected, the fast component is to the left. Hence, it is called a left beating nystagmus. With the head in midline position, the fast component of nystagmus due to cerebellar pathology is towards the site affected. Hence, if the cerebellar pathology is on the right cerebellar hemisphere, the fast component is to the right side. Hence, the nystagmus will be called a right beating nystagmus. So the answer to this question is true. Next question. All nystagmus are abnormal. True or false? 3 types of nystagmus are considered physiological by many authors: endpoint nystagmus, fixation nystagmus, and caloric nystagmus. The diagnosis of physiological endpoint nystagmus is one of exclusion. To diagnose physiologic endpoint nystagmus, no other ocular finding indicating pathology can be present. It must be present only on extreme lateral gaze and be horizontal with a minor torsion. It must stop if the eye is allowed to go a little towards the primary position. It must be symmetrical, and no other explanation for it must be present, such as not taking a drug that produces nystagmus. Physiologic fixation nystagmus must also meet a very strict criteria. This type of nystagmus is characterized by fine oscillatory movements that occur during maintenance of fixation, but it is only detected during nystagmography. It should not be clinically appreciated in a regular exam. Another type of physiologic nystagmus is optokinetic nystagmus. We can appreciate this type of nystagmus when traveling in a train and fixating our gaze in a target, such as a picket fence, hence the term used for this type of nystagmus, either train nystagmus or picket fence nystagmus. At the office, we can elicit this nystagmus using an optokinetic strip or an optokinetic drum. The third type of physiologic nystagmus is called physiologic caloric nystagmus. Physiologic caloric nystagmus is elicited during caloric testing. When ears are studied separately, the mnemonic rule cows work as we explained in a prior video. When both ears are irrigated at the same time, cows does not work. Hot water in both ears will slowly move the eyes up, followed by a quick down jerk, and cold water in both ears will produce slowed down eye movement with a quick up jerk. The answer to this question is B. Next question. In a comatose patient with intact brainstem, warm water, simultaneous caloric testing in both ears, and down-turning those maneuvers produce eye movements in the same direction. A true, B false. In comatose patients with intact brainstem, only the slow components will be present. So, after confirming the absence of tympanic membrane perforation, we introduce a rubber needle and put hot water in both ears at the same time. The eyes will drift and stay up for a while. Bilateral warm caloric testing is equivalent to down-turning dose maneuver. In both situations, eyes go up. On the other hand, if we decide to test the ears with cold water and we follow the same procedure as indicated here, When the cold water is injected, both eyes will drift down and stay so for a few minutes. Bilateral cold water calorics is equivalent to upturning dose maneuver. In those situations, eyes go down. So the answer to this question is true. Next question. The Epley maneuver is good to treat vestibular neuritis. A, true, B, false. In the process of answering this question, we will consider frequent peripheral causes of vertigo. We will start talking about labyrinthitis. I hope by now you recognize the different components in this figure. Here I am indicating to the labyrinth. Labyrinthitis is an inflammation of the labyrinth, but as you know, there are two labyrinths, a bony one and a membranous one. Again, I hope you recognize all elements in this figure. The white line is the compacted petrous bone forming the bony labyrinth. The black line is the membranous labyrinth. Labyrinthitis is an inflammation of the membranous labyrinth. As you can see, I have made the line red to indicate the location of inflammation. Labyrinthitis are classified according to the condition that caused them. So we talk about tympanogenic if the pathology affecting the labyrinth arose from the middle ear, post-traumatic if the initial pathology was a temporal bone fracture, meningogenic when the source of inflammation was the CSF, and hematogenic if the source of labyrinthitis is considered to be the blood. Clinical manifestations of labyrinthitis are vertigo with all the characteristics of peripheral vertigo, nystagmus with all the characteristics of peripheral nystagmus, and hearing loss. This is an MRI of a patient with labyrinthitis. This is the normal left 8th cranial nerve. I am now pointing to an abnormal semicircular canal. Notice that it enhances. Now I am pointing to the right 8th nerve. Notice the lack of enhancement of the right semicircular canal. So we have talked about labyrinthitis. Now we are going to talk about benign paroxysmal positional vertigo. Another condition that affects the labyrinth is benign paroxysmal positional vertigo. Clinical manifestations of benign paroxysmal positional vertigo are peripheral vertigo, peripheral nystagmus, but no auditory findings. The cause of benign paroxysmal positional vertigo is free-floating densities called canalith located in the semicircular canal. Usually the posterior semicircular canal is the one affected. These densities deflect the cupula, creating a sensation of vertigo. I will illustrate this phenomenon in the next few frames. The black blobs in this drawing represent the free-floating densities I just mentioned. They are usually referred to as channel rocks. When the rocks, as a consequence of a change in position, move, they tilt the ampulla away from the utricle, and when they move in the opposite direction, they push the ampulla towards the utricle. These rock movements trigger unilateral activation or inhibition of the labyrinthial signal. The unmatched activation or inhibition leads to vertigo and nystagmus. The treatment of this condition is a set of exercises proposed by Dr. Epley. They are called the Epley maneuver, which I use for middle-aged and older patients. In younger patients with no neck issues, I like to use the Foster maneuver. This maneuver starts with the patient kneeling head up, which move the stones down by gravity. In the somersault position, that is the next position, the stones change, always pulled by gravity. So it does when the head is turned up to the right, when raised, and then when turned. The aim is to send the stones to the utricle, or at least where they do not trigger endolymph circulation. These positions are crafted to promote the migration of the little stones in the posterior canal, which, as previously mentioned, is the semicircular canal most often affected in this condition. So that is for benign paroxysmal positional vertigo. Now I will address Meniere's disease. Meniere's disease is a disorder of the labyrinth. This condition was described by Prosper Meniere. He localized the pathology to the spatial organs, meaning the ear, at a time when many contemporary physicians thought that the pathology was in the brain. In this frame, you see a normal membranous labyrinth. Notice its size in relation to the green perilymph. The new image shows a swollen membranous labyrinth. Most of the green is gone. This phenomenon is referred to as endolymphatic hydrops. Now I am going back to the proper Meniere frame so you can see about treatment of this condition. Treatment of this condition in the 1800s consisted of bloodletting and purging, which he pointed out that it did not work. One of Dr. Meniere's greatest contribution was to prove that in this condition such treatment were inappropriate. Endolymphatic hydrops, based on etiology, is divided into those with a known pathology like trauma or tumor. This is an example of a vestibular schwannoma producing swelling of the endolymphatic sac, better appreciated by the bulging of the vestibular or Reisner membrane. I have added a drawing of the cochlea so you can get a better idea of where this is. When the etiology of the endolymphatic hydrop is known, we talk about Meniere's syndrome. When unknown, we use the term Meniere's disease. Clinical manifestations of Meniere's syndrome are a mixture of those produced by the cause of the pathology and the hydrops. The clinical manifestations of Meniere disease are limited to those produced by the hydrops. They consist of spontaneous episodic attacks of tinnitus lasting from minutes to hours, most often 2 to 3 hours, aura of fullness, which is episodic, vertigo, also episodic, and fluctuating hearing loss but with gradual decline. The hearing loss in patients with Meniere disease is sensory neural, and it affects lower frequencies more than higher frequencies. This is unlike most other form of sensory neural hearing loss. Done with Meniere disease, I will mention that some drugs are known to produce vertigo by affecting probably the labyrinth neuroepithelium. Drugs at time producing vertigo are streptomycin, quinine, and salicylate. This is just to mention a few because there are many that do so. Next, I will address vestibular neuronitis. Vestibular neuronitis is a disease of the nerve. The segment of the nerve involved is usually the superior vestibular root. Think of this condition as the Bell's palsy of the vestibular nerve. The clinical presentation is characteristic of peripheral vestibular disease with no cochlear involvement. These patients usually have peripheral vertigo. Vomiting is a very prominent feature, and also is nystagmus, but there is no hearing problems. This is an MRI of a patient with vestibular neuronitis. You can see enhancement of the left vestibular nerve. So the answer to this question is false. Next question. DASH is considered by some authors to be due to central vestibular pathology. A. Benign paroxysmal vertigo of infancy. B. Superior semicircular canal dehiscence syndrome. C. Benign paroxysmal positional vertigo. D. Meniere's disease. Central vertigo occurs due to brainstem involvement in the vestibular nucleus or proximal connections including the cerebellum, or with brain lesions. The first condition I mentioned in this question was benign paroxysmal vertigo of childhood. This condition is considered by some to have a central origin, while other authors consider benign paroxysmal vertigo of childhood a vestibular apparatus disorder. As just stated, the etiology of this condition is unknown, hence hypotheses about its anatomical substrate are multiple. Some place it at the labyrinth, others at the brainstem, while others blame the brain. Benign paroxysmal vertigo of childhood usually first appears at 2 to 4 years of age. It is characterized by brief episodes, usually of 5 minutes or less, that resolve completely. These episodes consist of vertigo, anxiety, fear, nausea, and sweating. The episodes start decreasing in frequency after about a year of their onset and are usually gone by 5 to 10 years of age. After benign paroxysmal vertigo of childhood, I want to mention superior semicircular canal dehiscence syndrome. The superior semicircular canal dehiscence syndrome is due to a third window in the superior semicircular canal which puts the membrane labyrinth in contact with the CSF. It is called the third window because of its similarity with two other windows in the bony labyrinth, the oval and the round windows. The presence of this window manifests by vertigo and nystagmus triggered by loud sounds or pressure changes in the middle ear or CSF. Patients with this condition suffer vertigo and nystagmus when in a loud environment or during Valsalva, or also in the office during the fistula test. The fistula test consists of applying a positive pressure to the ear through a pneumatic otoscope. In such cases, we will see vertical torsion with the slow component being directed away from the dehiscent labyrinth. The diagnosis is made by high-resolution CT. A little opening is present in the superior semicircular canal, as illustrated here. So the answer to this question is A. Next question. Facial palsy is not a usual finding in patients with Wallenberg syndrome. A true, B false. Among one of the most dreaded causes of vertigo is vestibular stroke. At times, vestibular stroke is preceded by vertebral insufficiencies or posterior fossa transient ischemic attacks. These attacks are frequent in the elderly and by definition must last less than 24 hours, usually lasting about 8 minutes. Their presence is an indication of a possible stroke to come. To understand vertebrovascular stroke, we must know facts about 3 different elements. One is brainstem circulation. That is about vertebrovascular circulation. The vertebrovascular circulation is rather simple. The vertebral artery climbs close to the cervical vertebral column, giving some fibers to non-neurological branches such as the posterior meningeal artery as well as to the spinal cord. Once it has gone through the foramen magnum, it gives off the posterior inferior cerebral artery and the anterior spinal artery just before joining its counterpart and forming the basilar artery. The second element we must know before addressing vertebrovascular stroke is regional anatomy of the brainstem. The blue rectangle indicates the level of a cut, which I have represented here, and here in a full front view. This is the inferior olive. In the back, we have the open fourth ventricle, indicating that we are dealing with the upper medulla. The third thing we must know is the actual upper medulla artery supply. 3 arteries are involved. The anterior spinal artery irrigates the medial part, the vertebral artery the middle region, and the pica irrigates the lateral posterior region. The cause of vertebrovascular artery infarct involving the vestibular nucleus usually is obstruction of the pica, with subsequent failure of irrigation of the posterior lateral region of the upper medulla. This is usually due to arteriosclerosis, emboli, or vertebral dissection. The constellation of findings that result from ischemia in the territory irrigated by the pica is called Wallenberg syndrome. There are 7 major structures involved in Wallenberg syndrome. One is the spinocerebellar tract. The second is the inferior cerebral peduncle. The result of damage to this structure will be decrease in muscle tone and ataxia, both ipsilateral to the lesion. The third structure involved in this syndrome is slightly medial to the one we mentioned before, here represented in green, the spinal trigeminal tract and nucleus. Damage to this structure manifests by ipsilateral facial, loss of pain and temperature. The fourth structure is medial to the spinal trigeminal tract and nucleus, represented here in purple. This structure is the nucleus ambiguus. Damage to this nucleus manifests by ipsilateral palatal weakness that produces deviation of the uvula towards the normal side, and also paralysis of the ipsilateral vocal cord that manifests by failure of ipsilateral vocal cord to close during the end of inspiration or open during phonation. The fifth structure involved is located dorsal to the spinal trigeminal nucleus, the vestibular nucleus. The vestibular nucleus involvement will produce balance and extraocular muscle problems. The balance problem will consist of a sense of veering to the side ipsilateral to the lesion, at times even causing the patient to fall towards the side of the lesion. The second consequence of vestibular nucleus involvement is extraocular movement abnormality. I hope you recall this cartoon from the previous lecture on physiology of the vestibular system. Damage to the right vestibular nucleus complex will affect lateral eye movements in the following way. Decreased activity of the right vestibular nucleus complex will translate into a relative increase activity of the left vestibular nucleus complex, as indicated here by the green upward arrow. The relative increase will increase activation of the right PPRF and then an increased activation of the right sixth cranial nerve nucleus, which will have two consequences. One is transmission of the activation to the left third cranial nerve nucleus, with subsequent activation of the medial rectus. The other one will be activation of the right lateral rectus, producing slow deviation of the eyes towards the right side, as you can see here, very slowly moving towards the right side. This is followed by activation of the right eighth cortical area, which activates the left PPRF, triggering a corrective saccade to the left that places the eye in the primary position. Yet the tendency for the eye to be pulled towards the involved medulla will remain, so these patients usually tend to be looking towards the side of the lesion in the medulla. This nystagmus, although occurring in the central nervous system, has the characteristics of peripheral nystagmus regarding its direction. Other types of nystagmus may also occur in this syndrome depending on the extent of the lesion. The sixth structure involved is located anterior to the spinal trigeminal nucleus, and it is called central sympathetic fibers. Damage to these fibers produce Horner syndrome, that is ptosis, meiosis, and anhidrosis. It's lateral to the lesion. The seventh structure involved is found lateral and anterior to the spinal trigeminal nucleus. It is the spinothalamic tract. Damage to this structure produces contralateral body, loss of pain, and temperature perception. This is an MRI showing a left lateral medullary infarct. So the answer to this question is true. Next question. DASH is an overgrowth of desquamated keratin debris within the middle ear space. A. Osteoma. B. Tympanosclerosis. C. Cholesteatoma. D. Presbycusis. Of the three ways we have to diagnose patients: pattern recognition, algorithms, and application of basic and clinical knowledge, the diagnosis of the conditions mentioned in this question rely heavily on pattern recognition. Hence, you may want to see these otoscopic pictures more than once and also review this condition in other textbooks. Osteoma is a true benign neoplasm of the bone of the external auditory canal. Osteoma is usually unilateral and pedunculated. Osteomas may present with pain or conductive hearing loss. This figure corresponds to a tympanic membrane perforation. Most of them improve on their own. Do not do caloric testing in patients with tympanic membrane perforation. Tympanosclerosis consists of a chalky white patch beneath the mucosal lining of the medial surface of the drum. Tympanosclerosis is usually asymptomatic and can be safely ignored. Mucoid otitis media is a middle ear problem that may cause conductive hearing loss. Mucoid otitis media is common in children. Otosclerosis is characterized by local, focal, and non-inflammatory bone destruction and disorganized re-deformation. Otosclerosis presents as a sudden or slow onset of unilateral conductive hearing loss. The second ear may be affected years after the first one. Cholesteatoma involves the middle ear. Normally, the middle ear has no desquamated keratin debris deposition. In patients with cholesteatoma, probably at some point there was a perforation of the eardrum and desquamated keratin debris from the external ear canal cut into the middle ear. In the middle ear, the desquamated keratin debris grows and damages it. Cholesteatomas produce conductive hearing loss. Now we will talk about aging and one of its consequences, which is presbycusis. This is an audiogram. Noise level is given in dB, frequency in hertz. Being able to hear noise above 20 dB is considered good hearing. This is represented in this frame by the magenta line. Good hearing is an attribute of youth. By 40 years of age, high-frequency sounds have to be louder to be heard by most people, and louder still by 60, and more so by 90. This condition is referred to as presbycusis. Presbycusis is an aging-related progressive bilateral symmetrical sensory neural hearing loss involving higher frequencies, as we can see in this audiogram. Remember that in the cochlea, the hair cells for high-frequency hearing are at the base, and for low frequencies at the apex. In patients with presbycusis, there is destruction of hair cells at the cochlear base, where higher frequencies are heard. Low-frequency hearing is spared. So the answer to this question is C. Next question. Acute otitis media in children is always a benign condition. A true, B false. In order to answer this question, which I am sure you all know the answer to, I will tell you about a patient I saw many years ago. Please stop the video and read the case history. One of the salient points of the history is the presence of frequent episodes of otitis media. Acute otitis media is frequent in children. Most acute otitis medias are viral, others bacterial, and others are non-infectious. The most common bacterial infection is Streptococcus pneumonia and closely followed by Haemophilus influenza. Among non-infectious causes, we have Langerhans cell histiocytosis and Wegener's granulomatosis. The vignette also mentions glomerulonephritis, saddle nose deformity, Horner syndrome, and lung involvement. This cluster of findings indicate a generalized condition affecting upper and lower airways, kidneys, and bones. This patient was diagnosed with Wegener granulomatosis based on clinical grounds and the presence of anti-neutrophil cytoplasmatic antibodies against proteinase 3. This condition is also called granulomatosis with polyangiitis. It is characterized by a triad of focal necrotizing vasculitis, necrotizing granulomas in lung and upper airways, and necrotizing glomerulonephritis. So the answer to this question is false. Next question. Patients with bilateral vestibular schwannoma are likely to have type 2 neurofibromatosis. A true, B false. Vestibular schwannomas are rather frequent in patients with neurofibromatosis type 2. They usually involve the cerebellopontine angle, which we will delineate in the next few frames in order to understand the plethora of clinical findings that can be seen in these patients. This is a frontal view of the cerebellum and brainstem. Here you can see the pons, medulla, and cerebellum. This area corresponds to the cerebellopontine angle, which I have enlarged here to point to you the cranial nerve present in this region. The 5th, the 6th, 7th, and 8th, 9, 10, and 11. But especially notice the proximity of the 7th and the 8th cranial nerve. The clinical manifestation of tumors in this area are tinnitus, hearing loss, nystagmus at time involving only one, but more often involving both eyes and producing positional nystagmus. They have episodic or positional vertigo. At times, cerebropontine tumors present with facial palsy. Facial palsy can also develop after other symptoms are already present. Facial numbness may also be present, usually not early in the course, but it tends to be a late occurrence. Facial numbness is due to cranial nerve 5 involvement. At times, patients also develop ataxia, dysmetria, and disequilibrium due to cerebral involvement. It is important to realize that while mild intermittent peripheral vertigo may be the initial symptom, with time, finding of central vertigo, followed by multiple cranial nerve and cerebellar signs will appear if untreated. This is an MRI of a patient with left vestibular schwannoma. Notice the mass in the pontocerebellar angle. This is an MRI of a different patient. You can see a falcine meningioma, as well as a right vestibular schwannoma with significant pontine infiltration, and a left vestibular schwannoma also with significant brainstem infiltration. The presence of bilateral vestibular schwannoma is indicative of neuropharyngomatosis type 2, which, as you know, is associated with chromosome 22. So the answer to this question is A, true. Thank you very much for your attention.